So are there any particular types of cancer that are seeing a lot of changes today?
I suppose when it comes to chemotherapy, we kind of there's two major areas that we look at using chemotherapy for. One is patients who've had a cancer removed, and we give chemotherapy to decrease the risk of the cancer coming back after a surgical operation to remove it. That's very common in, for example, breast cancer, colon cancer, and a number of other areas. And that type of chemotherapy is called adjuvant chemotherapy. And the aim of that chemo is to decrease the risk of the cancer coming back in the future. And I suppose we need to weigh up the risks and benefits of that approach in every individual patient, because while it can decrease the risk of the cancer coming back, it can also cause side effects and toxicities. One of the main toxicities from any chemotherapy that we use is lowering of the immune system. And in the era of a COVID outbreak, lowering the immune system has extra risks involved, because it increases the risk of developing that illness and becoming very unwell from it. So that's an extra factor that we wouldn't have factored in 6 months ago, and therefore the risk-benefit ratio of administering adjuvant chemotherapy is altered because of that. So we have to take it, there's no blanket rules in this situation, but that is an extra factor that we take into account when we're deciding and discussing with our patients whether it's best to have chemo or not have chemo. Similarly, in patients who have cancer that isn't amenable to resection by a surgical approach, we use chemo sometimes to shrink and control the cancer for as long as we possibly can. And again, that chemotherapy can be effective at shrinking and controlling the cancer, but it can have side effects like lowering the immune system. And so we need to take that into account again in the era of COVID, where a lowered immune system has increased risks. So it's just one extra factor that we take into account. But I think it's important that patients are aware that we try to make the best decision for their individual case, and every oncologist around the country is doing that. Then there's other cancers that are kind of very slow-growing cancers, and that can be controlled by other means besides heavy treatment. So, for example, localized prostate cancer, which has a low likelihood of spreading to other parts of the body, that can be controlled with hormonal therapy. And by using hormonal therapy to control it for a period of months and even years, we can delay treating it with surgery or radiotherapy to try and kill it off completely. And again, when there's a COVID outbreak coming into the hospital, we try to minimize footfall in the hospital, and it's very reasonable to treat, say, a localized prostate cancer with hormone treatment and not any other treatments, because that's adequate to control the cancer, and then come in with the heavier treatments in due course when the situation stabilizes in the country. Other examples of that would be, there's some very slow-growing brain tumors that sometimes can be managed with simply surveillance. And by using surveillance, we can delay the need for surgery or avoid it completely. And that's a very reasonable approach for low-grade gliomas. So there's a number of different situations like that where people can, where the risk-benefit of intervention has changed.